Following repeat testing with MET gene amplification identified as a resistance mechanism, this patient was started on crizotinib. She experienced some diarrhea and visual disturbances, which are known side effects of this drug. Imaging at 3 and 6 months showed partial response. Imaging at 10 months demonstrated both progression in the central nervous system with brain metastases and also progression in the lung. A repeat biopsy and genotyping of the lung biopsy demonstrated an ALK-1196M mutation. Our second-line options following alectinib are a bit more limited than our second-line options following crizotinib. The only FDA-approved drug for post-alectinib progression right now is lorlatinib. However, there are other options. Brigatinib has been now shown in 2 studies to have a response rate of approximately 40 to 50% following alectinib or other second-generation inhibitors. The choice of crizotinib here is a bit unique and probably is worth discussing a little bit. So crizotinib is a first-line inhibitor and would not necessarily be thought of as a great option following alectinib. However, crizotinib has a unique property compared to all of the other ALK inhibitors, and that it also is a very potent MET inhibitor. And so I think the choice of crizotinib in this particular case, because of the MET gene amplification, does make sense, although not obvious based on the indications for these drugs. The one downside, of course, of crizotinib in this case is that although it covers both ALK and MET, which is important for this patient, it is not a very good CNS penetrating inhibitor, and as we saw in this case, the patient progressed after a relatively short time, both in the CNS and the lung. We mentioned earlier this patient's PD-L1 status or PD-L1 TPS score was 20%. So one question that might come up is, would we consider immunotherapy? Immunotherapy agents have become a very exciting option for a lot of lung cancer patients. However, in this case, I would definitely not use a checkpoint inhibitor or an immunotherapy. And there are multiple reasons for this. First of all, the patient has a low TPS score of 20%. However, it's important to note that even if this patient had a very high score of 80 or 90 or 100%, I would still not use an immunotherapy. This patient is a never smoker. Immunotherapies tend to work far less well in never smokers. And retrospective data and some prospective data suggest that immunotherapy in ALK-positive patients is particularly ineffective with very low response rates. And so I would recommend highly against using an immunotherapy in this case.